All right, so what are our objectives today? Just understand the management of perinatal infections during pregnancy and labor and delivery, describe the risk of vertical transmission, and guide our decision-making regarding mode of delivery, understanding the interventions available for minimizing transmission, identify the guidelines on use of antiviral therapy, and describe the risks and benefits of breastfeeding in patients with perinatal infections. Well, prenatal care plays such an important role in this. So our goal with prenatal care is to help ensure the birth of a healthy newborn and minimizing the risk for mom. The three components for prenatal care would be a risk assessment, health promotion and education, and therapeutic intervention. So what do we do in pregnancy? Well, throughout prenatal care, there are certain times when we check for certain infectious diseases, and I'm going to go over all the times that we do screen for that. So initially with the first prenatal visit, we screen for HIV, hepatitis C, hepatitis B, syphilis, chlamydia, gonorrhea, and assess their risk for any history of herpes or herpes simplex syndrome, especially genital herpes. And then again, at 28 weeks, we recheck for syphilis. And if they tested positive for hepatitis C antibody, then we recheck for a viral load. Again and again on labor and delivery, we are checking syphilis again and hepatitis C. And again, if any of the other infectious diseases in pregnancy they're high risk for example, if they tested positive chlamydia and they were treated, we repeat that testing at 4 weeks. If they continue to have risk factors for acquiring hepatitis C or B or HIV, then we are screening them multiple times in pregnancy. And especially for syphilis, I've noticed, I've been out of residency and as an attending for about 12 years now since residency and now. And we used to only check for syphilis once in pregnancy, and the guidelines have changed because we have seen such an increase for syphilis here in West Virginia. So now we check them 3 times. Initially at the first visit, 28 weeks, and upon admission to labor and delivery. Well, why do you care so much? Well, prenatal care is our time to try to limit vertical transmission. What is vertical transmission is when the pathogen passes directly from mom to baby through either the placental barrier, delivery, or breastfeeding. And our goal throughout prenatal care and labor and delivery is to try to cut down as much as possible on that risk. So what are the risk factors that affect vertical transmission? Well, the viral factors, for example, the viral load. Does mom have any drug resistance? Does that virus have any drug resistance? Maternal factors, immunological status of mom, behavioral factors. Is she high risk for acquiring more viruses or more infections throughout her pregnancy? Any fetal factors, any prematurity for baby, any genetic abnormalities, even obstetrical factors like the mode of delivery. Did she have prolonged rupture of membranes? Did we do any procedures during labor and delivery? And again, newborn factors. We know their immune system is suppressed at the time, and any genetic abnormalities or any issues for baby. What is the risk for vertical transmission for certain infectious diseases? Well, HIV can be between 15 and 45%. Hepatitis B is at 10%. It could be as high as 60% if the infection is happening around delivery time. And hepatitis C, 5.8%, and even higher if they have a co-infection with HIV, up to 10.8%. Again, our goal is to decrease this viral load and decrease the vertical transmission. So one ways we can do that, decreasing the viral load for certain infectious diseases in pregnancy, decrease that exposure to vaginal secretions, treating the baby once the baby's born, and decrease exposure through breast milk. Just wanted to kind of go over all the different viral hepatitises and just kind of give a little bit of information about that. So some of the most common and potentially serious infections that can occur in pregnancies are viral hepatitises. There's 5 types: A, B, C, D, and E. And fortunately, with hepatitis A and B, they can be effectively prevented through vaccination. But as we know, not everybody is vaccinated for this, unfortunately. Usually our patients can present with malaise, fatigue, anorexia, nausea, vomiting, diarrhea, right upper gastric pain, It could be jaundice, upper abdominal pain, hepatomegaly. Their urine's usually dark. Their stools are usually gray or acolic. And in fulminant hepatitis, then we can see signs of coagulopathy or encephalopathy. And how do we manage these patients? Well, we manage pregnant women very similarly as non-pregnant patients. So we hospitalize them if they have any signs of encephalopathy or coagulopathy. We need to address their nutritional needs. We need to correct their fluid and electrolyte abnormalities. And if coagulopathy is present, then we need to administer the appropriate blood products, including FFP or cryoprecipitate. And if they're not as severely sick, they can be treated as outpatient. And as Dr. Feinberg mentioned last time, hepatitis C is such a big problem here in West Virginia. So we are trying our best to try to screen all our patients. And once we do, they do test positive. And then we are trying our best to make them follow up with our infectious disease clinics postpartum. Um, as we talked about last month, it has increased significantly, and that's due to the increased drug use here in West Virginia. And we'll talk a little bit more about that. So the principal risk factor for transmission is IV drug use and sexually. And what are the risk factors that could increase the risk of transmission? Well, we look at maternal viremia or the RNA viral load in pregnancy and the time of delivery. And unfortunately, viremia can be intermittent. So if somebody tested negative earlier in pregnancy, they can test positive. So they get tested multiple times throughout pregnancy. If they do have antibodies to HCV, but negative viral loads, virtually really cannot transmit to their to their infants. So that's important for us clinician to be aware of that. And if they are co-infected with HIV, they're much higher risk of having higher RNA levels just because of their immunosuppression due to HIV. If they are using drugs, the IV drugs, then they're 1.5 times more likely to. What else can increase the risk of transmitting hepatitis C? Well, anything that could be invasive or any invasive prenatal testing, prolonged rupture of membranes, any obstetrical procedures. And you're looking into the different prenatal testing that we do, amniocentesis, as we go in through the mom's belly and pull out some amniotic fluid to test for any genetic abnormalities. Has limited data, but has not been shown to increase that risk. CVS has really no data on it. Therefore, if invasive prenatal testing is necessary, then we recommend amniocentesis over that. And then the risk-benefit ratio would be discussed with the patient. Studies have shown if there's prolonged rupture of membranes, especially greater than 6 hours to delivery, there's 9.3 times increased odds ratio. And obviously, the longer the rupture of membranes, that increases your risk too. Obstetrical procedures like the fetal scalp electrode. I don't know if you guys are all aware of what it is a little electrode that we put on the baby's head during labor to try to get the baby's heart rate. And that kind of goes inside the skin, inside the scalp. So that could be increasing, obviously, the risk of transmission. So we try to avoid that with hepatitis C and some other infectious diseases. And a lot of time we use that when we're not able to monitor the baby's heart rate externally with an external monitor. Studies have shown that HCG genotype does not has an association with vertical transmission. The mode of delivery does not appear to be associated with increased risk. However, if the patient is infected with HIV, obviously, then that transmission risk is based depending on the HIV status at the time of delivery. And then we'll have to kind of alter that mode of delivery at the time. Breastfeeding does not appear to increase the risk. However, if patient has any cracked nipples or any bleeding, then we recommend not breastfeeding at that time until everything's healed. When they've looked into the breast milk, they do detect HCV RNA. However, transmission from breast milk to infant has not been documented. And the reason why we believe that breast milk itself has can inhibit HCV infectivity due to disrupting the viral envelope, and the acidity of the infant's stomach can also decrease that risk, and along with the very low RNA levels in the breast milk. So that's good. Again, if patient is co-infected with Hep C and HIV, then that increases the risk of transmission and increases the risk of more severe hepatic injury. And I know Dr. Feinberg talked about this last time. ACOG at this time, or the American College of Obstetrics and Gynecology, does not recommend treatment of hepatitis C in pregnancy at this time, but we are really hoping with more studies and more extended time with the studies, then we will soon, hopefully, will be offering that. But our goal right now as OBGYNs is increase screening prior to pregnancy, increase follow-up postpartum for our patients to get their treatments. So ACOG recommends that we screen all patients for Hep C viral antibodies in each pregnancy. And like I said, we want to try to catch these patients before getting pregnant. That way we can offer them treatment. And obviously, if we do recognize that they are positive in pregnancy, then refer them for treatment postpartum. And the timing of transmission has been looked into before. That can infants can be infected perinatally, either intrauterine or intrapartum. And the way we know how intrauterine transmission could be possible is whenever infants are tested really a few days after delivery, and they have HCV cRNA in their blood. That means that the transmission most likely happened during pregnancy, because it takes a few weeks usually for the cRNA, keep saying cRNA, HCV RNA levels to be detected. It takes a few weeks for it to be detected in infant's blood after delivery. So that's how we can tell that some fetuses have been exposed earlier on and not just during delivery. Important to note too, some infants can have positive HCV antibodies in their blood, and that's most likely from placental, the mother's antibodies going through the placenta for babies. So that's important that's why babies get tested multiple times throughout the first year. And I'm going to let the pediatricians talk about that later on, but it's very possible for the babies to have antibodies early on. That's due to the mom's antibodies. I wanted to talk about the other, especially hepatitis B, just because it's something that could be very highly preventable. And we screen that in pregnancy, and hopefully we're able to treat everybody that's testing positive. Mortality associated with acute hepatitis B is approximately 1%. 10 to 15% of patients develop chronic infection, and 15 to 30% of those with chronic infection continue to have viral replication. It is highly pathogenic and infectious, and worldwide perinatal transmission represents the single largest cause of infection in individuals worldwide. So it could be as high as 90% without maternal antiviral therapy or neonatal prophylaxis. So that's why it's very important to recognize that in pregnancy and start treatment if it is positive. We screen everybody at their first prenatal visit with a Hep B surface antigen, and if that's positive, then we have an algorithm to test for the other hepatitis B. Again, ACOG recommends triple panel screening for patients who have not had a documented triple screen and they're older than 18, who have not completed the hepatitis B vaccine series, and have an ongoing risk of hepatitis B, whether for their exposures or practices, and regardless of their vaccine history. Well, where do we check the hepatitis B is mostly in bodily fluids like semen and vaginal fluids, and usually transmitted parenterally and through sexual contact. So patients who are individuals who are at greatest risk are ones who are having unprotected sex with multiple sex partners, injecting drugs, or having sexual partners who engage in high risk behaviors. And those are patients that we would be checking multiple times in pregnancy and not just one time at the initial newbie visit. If a patient tests positive for hepatitis B, then we have to check the other blood work for hepatitis. ACOG recommends we start antiviral therapy if their viral load is greater than 200,000 to decrease the risk of vertical transmission. And that would be with tenofovir, 300 milligrams daily until delivery or up to 3 months postpartum. This is very rare. I've actually maybe only seen one throughout my career here. So I guess hopefully the risk is not as high here, but not seen that many of it here in Morgantown. Again, this is just an algorithm that kind of shows us what would be the next step to do. So we check her hepatitis B surface antigen. If it's negative, then, baby gets vaccination. If she's positive, then we're checking their liver enzymes, the viral load, and again, the other blood work for hepatitis. Repeat the load at 26 to 28 weeks. And if it's greater than 200,000, then we would begin treatment. If it's not, then again, the baby will be treated with the. And then if they test positive, and this is kind of the testing that shows, this is everybody's least favorite chart from medical school. But if you look at it here, this one kind of tells you what is an acute infection, chronic infection, is this a resolved infection? Are they immune to hepatitis? They've received the vaccine, or that will kind of know. So we got to test for all these, and that way we know exactly what category our patient would fall into. Well, what happens when they come into L&D? Well, patients who have unknown hepatitis B status or are continuing to have risk factors for infection, then they get screened again upon admission. And unfortunately, still up to 18% of pregnant women still do not have hepatitis B screening during pregnancy in the US. And most likely for patients who are probably not receiving any prenatal care. Um, So what are the indications for C-sections for the hepatitis B? Well, it could be just any obstetric indication. There's no special indication for hepatitis B. They could have a vaginal delivery. And then neonates who are hepatitis B positive, or if the moms are unknown, then they would receive the HBV vaccine within 12 hours. We do encourage moms to breastfeed, but again, like hepatitis C, then we recommend if the skin is cracked or bleeding to hold off until it is healed. We do on L&D, at least here, we give the babies a bath hepatitis with hepatitis C moms immediately after delivery, just to kind of decrease those secretions on the baby. Just switching gears here to HIV. Our goal with HIV in pregnancy is to decrease the perinatal transmission as much as we can, and treatment of mother during pregnancy and the neonate the first 6 weeks after birth and during labor could significantly decrease that transmission rate. Transmission can occur during uterine contractions, exposure to the virus and maternal cervical vaginal secretions, exposure to blood at delivery. And the risk of the mother to child transmission is directly proportional to the viral load. So the viral load in pregnancy is very important. Viral load at delivery is also very important. So when do we check for HIV? Well, for screening, we do that at the first visit. Like I said, anytime there's increased risk, we screen them multiple times. But if they are positive, then We check their viral load 2 to 4 weeks after initiating treatment, monthly until the RNA levels are undetectable, and at least every 3 months during pregnancy, and specifically at between 34 and 36 weeks of gestation to kind of plan ahead for delivery. Are they going to have a scheduled C-section? Are they going to be able to labor? And that way we inform mom and talk to her about her risks and benefits. For for patients who have HIV viral loads greater than 1,000, we recommend a scheduled C-section at 38 weeks. And, ACOG, we have strict guidelines on medically indicated timing of delivery, usually 39 weeks and above, unless it's medically indicated, and HIV would be medically indicated delivery at 38 weeks, just to try to decrease the risk of preterm, well, it wouldn't be preterm, labor or premature rupture of membranes, and that way they can avoid that exposure. This is just another table that kind of tells you, is this a risk for HIV transmission? Low risk, high risk. Between 50 to 1,000 would be, less than 50 would be low risk, less than 1,000 still high risk, greater than 1,000 would be the highest risk. And the preferred mode of delivery, greater than 1,000 would be scheduled C-section. And I will talk about the therapy that we would give upon patients presenting to L&D. So we give IV zidovudine, ideally 3 hours preoperatively, and then 1 hour IV loading dose followed by continuous infusion over 2 hours until delivery. If the patient opts still for a vaginal delivery despite having a higher viral load, then IV zidovudine should be started immediately upon their arrival. And again, that's another table. Is everybody going to have access to this PowerPoint? That way they can keep it? Yeah. Okay. And then this is the column where patients, if they did not have any medication during pregnancy or had unknown and very high risk for HIV or diagnosed upon admission, they would be in the very high risk category. Again, patient autonomy is very important. So patients are very excessively counseled about their risks of transmission with HIV, but they can still choose to go proceed with the vaginal delivery if they desire. So the patient's decision should be respected after they've been extensively counseled. And this is a great thing to kind of have if you're somewhere with low access and you have somebody presenting with HIV without a plan ahead of time, or you find that they're positive upon admission to L&D. There's a hotline that you can call this 24/7, and they will help you rapidly develop an individualized plan. Breastfeeding is not recommended with HIV. Even though mothers with viral suppression appropriate treatment around pregnancy in less than 1,000, the transmission risk appears to be less than 1%, but it's still not zero. So we don't recommend it. And again, without viral suppression, definitely not recommended. But you will have some patients who still, regardless, are still wanting to breastfeed. And I just added the slide on here. I'm not going to go over it, but if, that decreases your risk as much as possible to transmit if they do want to breastfeed, against recommendations. And then moving on to syphilis. I know it's a lot of info here. I was trying to get all the infectious diseases here. Congenital syphilis, the result of transmission of syphilis from the infected pregnant patient to the fetus at the time of pregnancy, mostly during pregnancy and rarely during childbirth. So why do we care so much? But if it's not treated, it can cause miscarriage, stillbirth, high drops, premature delivery, and perinatal death. And this is just kind of talks about congenital syphilis and all the findings that you would have that with it. So the rate of fetal infection depends on one mom was infected and the stage of the syphilis during her pregnancy. So the higher risk would be occurring during the primary and secondary stages. and or if the titer is greater than 1 to 8. We have seen infections also in latent, and with low titers also. This is another algorithm. Algorithms are pretty helpful when it comes to these blood tests that we do, and this will tell you, we usually do check for RPR initially, 28 weeks, and upon admission to LND, and this kind of tells you what the next step is. If you're obviously not sure, talk to your maternal fetal medicine experts or infectious disease experts, and then they can kind of guide you in the right direction there. Well, why do we care so much? My goodness, syphilis has increased, congenital syphilis has increased by 755%. And I have actually noticed that throughout the years. We have had at least 2 pregnant patients with neurosyphilis that were admitted. We have seen way more, I feel like, syphilis cases lately than when I first started. 88% of congenital syphilis could be preventable, and 2 in 5 infants with congenital syphilis were born to patients who did not receive any prenatal care. So that's why it's very important to screen them outside of pregnancy, in pregnancy, and follow up postpartum too. And yeah, that's why it's so important to screen these patients, because they're not always coming to their prenatal visits. They're a lot of time getting their prenatal care or just checking up on the baby in the emergency room. So that's also a great time to screen them for syphilis. And then any like syringe service programs, any maternal and child health programs is always an opportunity to screen for syphilis. And that way we can decrease the risk of congenital syphilis and not just prenatally. So please encourage everybody to start increasing this screening process. Treatment is pretty simple. It's penicillin G, 2.4 million IM, and then timely initiation completion treatment, very important to the risk of congenital syphilis. We have had a couple patients with severe penicillin allergy that we actually desensitized in the ICU and then given them penicillin after that, and they did well. Apparently, there's also a shortage. So the FDA is approving, maybe Dr. Farmer might know more about that, the use of another medication here that's been used elsewhere in the world. And I wanted to talk about HSV real fast because I feel like it doesn't get as much attention. Genital herpes is also a great risk for developing mom and fetus and newborn, and it's usually transmitted during delivery. So it's very important to recognize any patients who have that history and then put them on the prophylactic doses and really investigate whether they have any lesions at the time of coming into labor and delivery. This is just a little reminder if we put them on daily suppression at 36 weeks. So anybody with a history of genital herpes, regardless if it's HSV 1 or 2, we screen that. We just get a history from them in pregnancy. We don't do any specific blood screening in pregnancy. But if they've had any lesions before, then we recommend they start suppression therapy at 36 weeks until delivery to decrease the risk of having a outbreak around time of delivery. If they've had multiple outbreaks in pregnancy, then we just start it, keep them on it the whole pregnancy. It's important to note if they have an outbreak closer to delivery time, because that would be an indication for a C-section. So patients who have a current active genital lesions or prodromal symptoms, even like vulvar pain or burning, then we recommend a C-section because it could be shedding the virus. And what we usually do when they come into labor and delivery, anybody with a history of genital herpes, or maybe it's their primary outbreak, then we do a very extensive exam of their vulva, vagina, and cervix. We have seen lesions only on the cervix and not on the vulva, and that would be a reason to do a C-section. Like I said, routine screening is not recommended. We do offer a C-section to somebody who has had, even in the 3rd trimester, they could still be shedding the virus for a long period of time, and that could be offer the a C-section. And then if somebody has any lesions, let's say on their back, thigh, or buttock, it's not an indication for a C-section. What we can do is try to cover up those lesions and to decrease the access to that. And then if the mom presents with PPROM or premature rupture of membranes, definitely start antiviral therapy, and that would have to be a discussion of risk-benefit ratio of 1 to deliver. So that's all I have about all the infectious diseases in pregnancy. And I just wanted to kind of think about what can we do to help this. Our goal is try to decrease this transmission risk, try to get everybody to get, treatment when they can. So we really want to try to screen everybody and refer patients for treatment, especially with hepatitis C. It's such a big issue here in West Virginia. Hopefully we can screen them and recognize them before they get pregnant, and especially postpartum, refer them to treatment. Most of these patients, unfortunately, are only getting their care or seeing physicians or providers during their pregnancy. So I just keep always thinking about what could we do on labor and delivery to try to get these patients to come back and see infectious disease, and brainstorming, should we have, ID come see them in the hospital, and then that way they have that rapport, and like make them an actual appointment before they leave. They know exactly when they're going and what time. We actually have a postpartum nurse that kind of checks on our patients, and I was going to talk to our department and see if we can start having her keep a list of all of our hepatitis C patients and just really make sure that they are following up, because we put those referrals in, and a lot of time I'm assuming they're not, either they don't have transportation or just not coming back, not for even for their postpartum visits. So if we can all kind of rally together and try to do that. And that is all I have. Any questions?